Good morning, everybody. My name is Juliana Susla, and on behalf of ISQua, I would like to welcome you all to today's webinar with Chris Cornew, a national collaborative to improve cardiovascular care, one hospital perspective. We are extremely honored to have Chris Cornew with us today, who currently leads a consulting practice as Senior Vice President of CG2. And I would like to say a few words about Chris by way of introduction. Christopher Cornew has been a leader in healthcare for the past 20 years, having served in leadership positions in academic medical centers and teaching hospitals. He also served as CEO of a community hospital, where he implemented strategies to increase quality outcomes and improve the patient experience. Additionally, he's been active in international health activities, partnering with health organizations to improve healthcare globally. Just to remind you, that Chris's presentation will last approximately 45 minutes, and we will leave 10-15 minutes for any questions that you may have at the very end. Please type your questions in the question box provided, and we'll do our best to get them all answered. I hope you enjoyed this presentation, and I'll just pass the control over to Chris. Just 1 second then. Perfect. Chris, over to you now.
Well, good morning, everybody. It's a pleasure to speak with you, or good afternoon in some parts of the world. I will talk to you over a couple different slides with regard to what this overall project was from both the national perspective, but then also from one hospital's experience, which was specifically where I was leading the project at a hospital in Chicago. So let's get started and talk a little bit about the specific project. We know that throughout the United States, as well as globally, there's a fair amount of concern with regard to cardiovascular disease. And one of the reasons that we identified this particular focus on a national collaborative around cardiovascular disease is because it's the commonest cause of death in the United States. We have established guidelines that are in existence and have been tested and are tried and true. And we also have a number of measurable metrics that have been used to really measure how well and how successful folks are with implementing specific strategies. Also, there are specific guidelines that have been followed to reduce mortality overall with regard to cardiovascular disease. And so as we looked to identify from a national perspective an area or a disease that makes sense for us to follow, cardiovascular seemed to be the most obvious, and specifically acute myocardial infarction, AMI, and heart failure, HF. For the goals for this collaborative, and we'll get into a little bit more detail about the nature and the scope of it, but the goals overall were to develop effective, replicable, quality improvement strategies and models for inpatient and outpatient settings. So essentially, we wanted to identify through a collaborative with a number of different hospitals what type of strategies would be most successful, identify their successful natures and attributes, and then apply them not only just to other hospitals nationally, but then move them up to other diseases as well. And that was a key part of this goal of this collaborative. We wanted to make sure that we were able to encourage broad sharing of ideas across multiple stakeholders and the adoption of quality improvement strategies and models in other clinical areas as well. We know that variability is very relevant with regard to how we measure cardiovascular care as well as other care activities throughout our industry. And we felt that it was very important for us to measure that as well. And so through the course of this presentation, what I'm going to try to convey is that there were a number of different metrics that we put into place, as well as specific quality improvement strategies that look to address the overall problems that we have with cardiovascular care. The last piece of this is that when we had relevant lessons, we wanted to make sure that we were able to then push those out to policymakers nationwide, and if we could, be able to convey some specific changes when it came to overall quality care for cardiovascular disease. The collaborative hospitals were 10 hospitals across the U.S., which are reflected on this slide right now. And the hospitals were selected based upon their high minority patient populations and high volumes for cardiac care, specifically, as I mentioned, with acute myocardial infarction and then heart failure. The study population was comprised of patients that were discharged with primary diagnoses of AMI and heart failure, and they were selected for the large extent of research and widely accepted national quality metrics that have been in place, as I had already mentioned. About 380 hospitals across the U.S. were identified because of this profile and were asked to be part of this collaborative. And part of the metrics that were used were metrics and information that's reported to the Center for Medicare and Medicaid Services, two of the ways that healthcare systems and hospitals are paid in the United States. 120 hospitals completed the initial letter of intent, and 30 were invited to complete full data application, of which 16 were visited, and then these 10 on this slide were formally accepted and selected to be part of this process. Each hospital was then able to form an interdisciplinary team that was comprised of an executive sponsor, project director, clinical leadership, quality leads, IT, information technology folks, nurse managers, patient registration admission directors, and a number of other folks to comprise this team. It was important that we had some of the key folks that I mentioned as part of this because of the nature of the work we were looking to do. The point of perspective that I speak from today, even though I'm not currently at this hospital now, was when I was at Mount Sinai Hospital, Chicago, I served as one of the executive sponsors for this project and was involved with it for the entire 30-plus months. As part of this collaborative, each hospital received about $200,000 US that were then matched in kind by each of the hospitals. And the project was designed to go over a 32-month period of time. And I have to say that the $200,000 that was provided to us in combination with the in-kind was never truly enough to make sure that we were able to achieve all the goals, so more additional funding usually was provided from each of the hospitals. As part of the ongoing collaborative nature, there were 7 collaborative meetings, monthly conference calls, site visits by program office staff, and monthly data reporting that was in place during the course of this project. There were a number of different components of this project. Again, as I mentioned before, it was a collaborative project that was testing some theories as well as using some new information that was in place. And so there were 5 different aspects of the components, and the first one was really the overall project management that was in place, which was from George Washington University, and they really worked with us on quality assessment review and were the key organization with whom we spent a fair amount of time working and that helped to lead the project with each of the collaborative hospitals. Race, ethnicity, and language is one of those aspects of this project where we are now trying to measure quality of care in combination with looking at race, ethnicity, and language to really help understand and derive the changes and disparities of care that we saw in cardiovascular care. The Health Research and Education Trust group has spent a lot of time focusing on race, ethnicity, and language, and were really key partners in helping us to understand not only just the extent of these specific aspects, but then also different ways that we can put in place systems and ways to ask questions of our patients that we were able to get to this specific information. A market assessment where we looked at the specific needs of the market was put into place, and we worked on that with George Washington University, and that helped us to understand a lot more of the dynamics of the specific communities which we serve. An institutional assessment, and that was completed by the Ohio State University, and the goal for that part of the project was really to understand how situated and how ready our organization was to implement change around these quality improvement projects or these initiatives. And so we had an inward look at the organization with regard to senior level folks, physicians, and others across the organization for how capable and ready we were to actually realize specific change at the organization. And then New York University spent some time really reviewing the overall process. And so they looked at the nature of this collaborative. It was one of the largest collaborators at the time and over a longest period of time. And what they did is they wanted to assess how well this overall project was going, what the different successes were, where there were barriers that were in place, and then overall evaluate how this process took place over the 32 months. So we had a lot of different moving pieces to this, and there were a lot of individuals that were involved in this project. And this slide just helps to provide that type of context with regard to the number of individuals that were part So as I mentioned before, this is a national collaborative project around 10 hospitals. And now what I want to do is to focus a little bit more with regard to our specific hospital goals. So I'm speaking about the hospital where I was during the course of this project. And our hospital project goal were these four, although there were a number of different aspects under each of these. But to implement effective and cost-efficient care models for heart failure and AMI, both in the inpatient and community-based settings. A lot of care at the time really was focused just on the inpatient because of some of the metrics that hospitals in the United States were really charged with measuring and reporting. And this was the first opportunity really to take a look at that broader perspective of inpatient and community-based settings. We wanted to improve quality metrics as measured by some core measures, which is part of the reporting for Medicare information, and then also measures of ideal care, which is more of a patient experience type of number of attributes that are specifically measuring how patients are receiving the care that they have. A third goal was complement existing performance improvement efforts and transfer successful solutions throughout all service lines. As I had mentioned, that's an overall goal of the project. And really, we wanted to make sure that we could test and prove some specific actions and improvement methods that then we can transfer throughout other service lines in the hospital. And then we recognized the importance, especially with the community that we had, where we needed to address the racial and ethnic disparities in access, continuity, and quality of care. And in many ways, this was subjective. We recognized that there were probably ways that we can improve this, and what we wanted to do was to understand more specifics about this during the course of the project, so that there wouldn't be as much variance when it comes to care provided for different racial or ethnic groups. When we looked at some of the different metrics, it was a quick snapshot during the course of the project of the specific metrics. And there's a lot of data on the slide, but to suffice to say, one of the things that we looked at specifically was this overall component or composite score, but looking at all measures and how we were able to perform. And one of the most important takeaways, and this slide speaks specifically about AMI, is how we were able to improve from the base year through to the end, and based upon a number of different metrics that we looked at. We looked at aspirin upon arrival, we looked at smoking cessation, we looked at cholesterol testing, counseling. There are a number of different metrics that we put together to help make sure that we were measuring appropriate cardiovascular care. And as we'll get to in a couple slides, we also stratified this information by race and ethnicity as well to see if there was any type of disparity based upon that race or ethnicity. For MI, we had really good results with regard to the improvement over time. And for heart failure, again, very similar improvements over the period of the time of the project, where we were able to grow our metrics very specifically. And as I mentioned before, a lot of these metrics had been reported anyway to our federal government with regard to some of our requirements and our participation in some other programs. But this gave us an opportunity to really influence those scores, as well as put in place some tried and true type of behaviors and quality improvements that would be able to make change happen. We wanted to make sure that we took a look at some of this information and really measured where our success was. And so here are two sample control charts with regard to two specific metrics. And what you end up seeing, obviously, is where we had some significant changes and some control that were below the upper limit and above the lower limit, and having some consistent trend of success with regard to some of the activities that we were putting into place. Again, on the lower left, we have the AMI composite score, and the upper right, we have the heart failure composite score. And again, examples of where we were able to achieve, through a lot of different efforts, some of the good successes with regard to our overall trends of data. I had mentioned before that we also looked at measures of ideal care, and these are more patient-centric approach to determining whether a patient receiving all critical aspects of care that he or she should, given based upon the clinical evidence that's in place. These were selected as a primary outcome variable because they reflected ideal and optimal care for patients. And so this slide reflects the AMI and heart failure scores over time, and then the trend with regard to how the AMI and heart failure scores did during the course of the project. And again, we recognized that there was good improvement based upon the activities we put into place and the initiatives that we were able to employ. We had a fair amount of focus with regard to readmissions in the United States, and we still do. And ideally, if we are putting into place really good initiatives to make sure that the patient leaves the organization, they're able to return, they are not returning to the hospital within a 14 or 30-day period of time, and that they are prepared for going back out into the community. And a number of the different activities we put into place really helped to make sure that we were able to see good compliance with regard to our overall activities and measures overall, which would be the blue lines up above, and then we were able to see a decline overall in heart failure readmissions, which is exactly what you want to be seeing. Now, we weren't always successful, but what we saw overall with the trend is that there's a nice correlation between the increase of the results from our initiatives and then also making sure that we're able to change some of the behaviors, and then also make sure that folks, when they leave the hospital, are able to return back into the community better prepared for care than what they might have been previously. So let me walk through a couple of the different types of initiatives we put into place, and I won't go through all of these, but when we looked at the inpatient quality improvement initiatives, here's a snapshot during the course of a 2 to 3 year period of time of activities we put into place. To begin with, we developed automated referral systems for counseling with regard to smoking cessation. So any patient that we identified when they were in the hospital that potentially had some sort of issue or that had the heart failure AMI, we were able to go ahead and get them into smoking cessation counseling very quickly. And what we saw is that obviously with that compliance, we were able to affect more patients, and we saw our compliance with regard to our scores and our metrics improve pretty significantly. But that was something we identified very early on. We revised the collection of race, ethnicity, and language data fairly early in the process, and this was consistent with some government reporting standards with regard to how you're asking questions, how you're collecting this information, and trying to get some standard information that's in place. And in a future slide, we'll talk a little bit about that. We had disease managers that were working on the units, and we had real-time and also daily identification of these type of patients so that we can start working with them pretty quickly and identify those patients so that they don't get lost among all the other patients within the hospital, and we can tailor them very specifically for some of the initiatives we are looking to put into place. Also in the very top, cardiovascular discharge contract. This was one of those aspects that I think was probably one of the most successful initiatives we put into place. And this, coupled with a few others, I think really led to some of the scores changing and also preparing the patient for when they left. What we did is we worked very closely with a number of individuals and some best practices to understand if we could develop some sort of quote-unquote contract that we would give to the patient for them to then leave with and have a very good, in one place, understanding of everything they need to do, what the results were of their visit, their stay in the hospital, and understanding of their pharmaceuticals, understanding of what they need to be doing once they leave, but really everything that's listed within 2 to 3 page document. Not only just that they would have this information, but even though it's not a legal binding document, it, from a psychological perspective, it really embraces the patient a little bit more. And what we did is we had the cardiologist, the primary care physician, and then also the patient sign this document that we are all agreeing that you will be following up appropriately, that here's the information, we've read it back to them, they've read it back to us, they understand the information. And so when they left the hospital, ideally they were better prepared. We also ensured that when they left the hospital, they not only had a primary care follow-up appointment, but they had a follow-up appointment within 7 days with their cardiologist as well. So that we were preparing them for when they left the hospital, that they would not be left out there wondering how they're going to make the appointment, what they're going to be doing, how they can access a clinic, or I can access physicians in the future. What we were doing is preparing them for leaving and then having in place something which was going to measure, which was going to make sure that they were able to focus very closely on their health and that they were able to manage their disease better. We also focused very closely on trying to make sure that we made it as easy as possible for the staff and the physicians. And we had a single cardiology admission order set that was developed that had all the core components into it and also streamlined the process from when they came in or presented, whether in the emergency department or other access points, perhaps a clinic, they were able to get into the hospital in a very appropriate way. We looked at also implementing ED chest pain order sets so that there was very specific application of evidence-based and then also the orders that we need to be put into place that helped to streamline the process. We saw that more education that we could provide is exactly what we need to be doing, and so we created heart failure calendars and pocket guides. And these were developed as takeaways for the patients when they left, and they would be key parts during the time each month or during the course of a year where they need to have potentially some sort of follow-up appointment, or when seasons change they could be more at risk, or their healthy eating tips that potentially are on the calendar at specific dates. There are other factors that potentially contribute to heart failure that were represented within the calendars. And ideally, the goal for this was to provide ongoing education during the course of the year as opposed to just a point in time when they're in the hospital. Toward the end of this, or the right-hand side of the slide, we talked about also doing a code heart procedure, and there's a little bit more detail on this in the subsequent slide. But essentially what we did with this is, as patients present to the ED, with a PCI, what we try to do is to make sure that that process was as efficient as possible. We had in the United States a time from presentation to treatment or to intervention, 120 minutes, which then became 90 minutes. And this process really helped to make sure that the folks within the emergency department as well as in the interventional areas were activated quickly, and we had a process in place that was able to address not only just the care of the patient, but then reflected in the scores as well. And then we created some other education materials in the bottom right-hand corner, discharge lounge for patients as they prepared to leave the organization, where we could spend some time helping educate them. And then also some additional educational videos that were on their TVs or their channels that are in their rooms, so they can continue to be as educated as possible about different things when they leave the hospital, and then be as prepared as possible for when they transition from an inpatient hospital setting back out into the community. Many more examples, but wanted to just talk about some of these that really help to influence or to affect the overall scores for our hospital. And many of these also were adapted from examples across the collaborative, and then also were adapted by others within the collaborative based upon information that we were able to provide as well. From an outpatient perspective, some of the initiatives really were focused on education and then providing activities or resources within the community that didn't exist. A little bit about our hospital. We were a teaching hospital in the immediate west side of Chicago, one of the poorest communities in the country. And so what we noticed and what we knew, not only just on our market assessment that was done as part of this project, but also through the work that our hospital had done over years, is that we lived, or that our residents or our patients lived in a food desert. And there wasn't a lot of access to quality health food, healthy eating, healthy living. And so as a result of this, what we did is we created a couple different aspects. We put in place some farmers markets that were able to provide on a regular basis some healthy, fresh food that was brought in locally from some of the surrounding areas outside of Chicago. And then also Operation Frontline Nutrition Initiative is where we were able to get some chefs within the Chicago area to come in and provide some teaching classes with regard to how to cook food better. So ideally not to necessarily cook with a lot of fat, to be able to cook more healthy, but any of these type of aspects of care that was going to help initially and long term to affect their overall health and around cardiovascular and, of course, AMI as well. We put into place some computerized physician order entry to help with the efficiencies, and then also the transition of that information, not just from the inpatient setting, but also to the outpatient setting, so that when patients return to the clinics for their follow-up care, and ideally that would end up being as physicians that are part of the organization that have seen the patient in the hospital, that information would be then following that patient to the outpatient setting. If they had smoking cessation counseling, you can follow up then with some information saying, we know that on this date you had some counseling and you committed to stop smoking. 10 days, 20 days later, has that still the case? Have you stopped smoking? Also education around the family, helping them to talk about how they can provide healthier living with regard to a family situation or a household, that they can be then discharged back out into the community and have a better chance of success. So training, and that goes to the training of caregivers to become smoking cessation facilitators. Not only did we just rely on the respiratory department that we had within our organization, there were many other people that became smoking cessation facilitators. So we had more folks that were able to provide this care, not only just in the inpatient setting, but then also in classes and settings when the patients leave and are discharged back out into the community environment as well. We became a smoke-free campus during the project, which was a key piece to help make sure that we not only told our patients that this is the healthy way to do it, but we lived it as well. We created a cardiovascular registry towards the right hand of this, where we were able to make sure that we are capturing the attributes and the specific nature of each of these patients when they potentially might need to come back in or have some touch points with other physicians, whether it be a primary physician or whether it ended up being a cardiologist, and then also keep them close within the system such that they are never left out there without some support. This gave us an opportunity to reach out to them at key critical intervals during the course of their stay, post-discharge, and then also when they go back out into their clinics or their daily activities and their daily routines. We were able to keep them engaged during the course of the project and then following up afterwards. We also looked at other aspects that influence health with regard to cardiovascular disease, such as diabetes, obesity, and other activities as well. We tried to make sure we incorporated those as part of our outpatient activities as well. Here, I mentioned before the Code Heart protocol. Here's a quick snapshot of that, not only algorithm, but what we did. And we tried to make sure that we were able to streamline the process as quickly as possible. And some of the things that we did with key process changes, we identified specific red folders that helped folks to understand that, here's this patient is moving through the hallways with these, this is why, and so we need to do everything we can to make sure that time is important and that we can get that patient where they need to go. And then specific checklists with regard to making sure that we are following through what we need to in order to make sure that we can get to a good outcome with regard to the time and the efficiencies with regard to this. We made sure there's an elevator key to access that's secured for security for transport to the cath lab, so we didn't have to worry about that type of impediment with regard to transfer of the patient from one place to the next. We made sure that from a measurement perspective, we took a look at an atomic clock that was not dependent on manual human intervention. It was an atomic clock where it had the same time throughout the hospital so that we could not rely on own timepieces. We could then go ahead and focus on a standard time that is in place throughout the organization as well. And as I mentioned, these activities as well as others really helped us to get that patient when they came to the emergency department through the process very quickly, less than 90 minutes, which is the ideal goal. And we were able to keep that in place for a long period of time, and even to this day as well, from what I understand. So race, ethnicity, and language, and this was a key important part of the project because cardiovascular disease, what we've heard throughout the research and what we've definitely seen in some subjective ways, is that the care can be variable depending upon the race and the ethnicity. And it could be through a number of different factors such as culture, it could be language barriers, it could be a number of different things. And so what we were looking to do with this component of the project is to really get to objective data collection and make sure that we are having some sort of consistency with regard to not only collecting this data, but then also measuring it compared to our quality indicators. So we revised classifications consistent with the federal guidelines, and it's really taking a look at a number of different aspects with regard to race. It's African American, it's white, it's Hispanic, and non-Hispanic, and then also with regard to whether they're English-speaking or Spanish-speaking. And this helps us to then tailor some of our activities and our initiatives so that we can be more successful with the care that we're providing. We also make sure that there was one person asking this information, so we did not end up getting multiple different responses, and this was done at the point of admission or when they first entered into the hospital. And we changed the question is, to what language do you use when speaking with your nurse or doctor? And instead of saying, what language you speak, what we were trying to do is to really get in our databases, as well as understanding how we can address this patient throughout their stay, is the specific language that they're going to respond to the best. And so we tried to come up with different ways that we were able to capture this. And we were successful with really putting into place, and we ended up being a pilot site for some of these changes across the collaborative. And we got some very good consistency with regard to this. So each hospital then adopted a standard and consistent approach that relied on the patient self-reporting of race and ethnicity separately. And as I mentioned before, this was consistent with U.S. government standards that were put into place in the 90s. So what we want to do is, as I mentioned before, really take a look at how these quality metrics are then stratified by race, ethnicity, and language. And what we found is that at our hospital, we really didn't see a lot of variability. And we measured this over time, and as I mentioned before, there's the subjectivity, meaning that we believe that this variability may be in place, but then when we looked at the objective data and measured everything, we really didn't see that there was a lot of variability. And so this was a key learning from the course of this project. And I have to say that throughout the collaborative, I think this was a consistent factor that came from it, that there really weren't, for the majority of the hospitals, there really weren't a lot of disparities from the reporting and once we got some objective data. Having said that, we know that we didn't demonstrate significant disparities, but we did think that we saw some potential disparities, and it was really revolving around the discharge contract that I had spent some time talking about. We saw that there was a greater use of the discharge contract in English-speaking post-AMI patients as opposed to Spanish-speaking post-AMI patients. And we thought that that was potentially because of language barriers, but I have to say with our hospital, we had our cardiologist as well as our staff, we had dual speaking. That usually is not an issue with the hospital. But what we saw is that potentially through cultural differences, or maybe there was some language barriers, or maybe it's the literacy of the patients. And when it came to literacy, what we did is all the information we provided in such a way that was at the right level or at a lower level than what you would need. So we tried to do it at the 4th grade level, 5th grade level, such that everybody would be able to respond and potentially able to grasp a lot of what we were talking about. And we weren't too overly clinical or medical with regard to what we were putting out to them with regard to follow-up care or information about their disease or the discharge contract. We really tried to tailor it specifically to what the majority of folks would be able to focus on. So in summary, as we start talking about some of the successes, I think that overall, the national model for collection of race, ethnicity, and language data was a success in that we've gotten to a very consistent way to be able to measure and to capture this information, and then also to review it. And while this was novel at the time we were doing this project, it's now pretty much the standard throughout all hospitals here in the United States to make sure that we are understanding any type of variability or difference that may be in place across these patients based upon race, ethnicity, and language. We increased the collection and reporting of quality data with some statistically significant increases, not with all metrics, but with some of the composite scores, and then also the measures of ideal care. We did see statistically significant increases during the course of those specific metrics. We implemented some very novel heart disease prevention strategies that work very well for our patient populations, such as the nutritional dietary training and instruction, which I talked about with Operation Frontline, and then also some of the fresh food markets that we brought to bear in the food desert that we had surrounding the hospital and that our patients lived in. Standardized order sets were a key piece of success for the project, and then also for use in the ED and also the care units. And we, through the medical staff and through working with the leadership throughout the organization, we were able to make sure that this was mandatory for all medical staff to follow, and we were able to get best compliance with regard to the outcomes of these activities. Some of the automated consult referrals, as I mentioned before, whether it's to respiratory for smoking cessation or end up being to a diabetes clinic if there's that indication, was a key piece of this. The creation of a discharge contract I've spoken about and was a very significant part of our success. Development of the Code Heart Protocol, which I had mentioned before, the smoke-free campus was a big piece of it, and then the increase with regard to the different types of education and communication, not just specifically some of these here, like the calendars and the guidebook, but also the education throughout the community for these. And one of the things that I want to mention too, so these were the specific successes with regard to the hospital, my hospital that I was working with at the time. But from a national collaborative perspective, it's important to note that of the 10 hospitals, 7 showed statistically significant improvement in both AMI and heart failure. 2 of those remaining hospitals showed improvement in both the measures of ideal care, but they just weren't statistically significant. All 10 hospitals were able to fully implement the standard collection of race, ethnicity, and language. And as I mentioned before, 7 of the 10 hospitals showed no significant disparities by race, ethnicity, and language during the initial 6 months. And any disparities that did exist were pretty much gone, and they had disappeared by the end of the project. So for those hospitals that did show some sort of disparities, they were able to essentially address those, and there were no further disparities that were shown through the data by the end of the project. So of the lessons learned throughout this project, here are some significant ones that I think are important. Key metrics can be measured, and key metrics can be improved by using and sustaining innovative process improvement methods. The metrics improved, as we mentioned, and they continue to be very high based upon the work that we had done, and we were able to hardwire or put into place these type of activities that have remained at the organization, such as the discharge contract and others throughout the project. Communication is the key to success, and I cannot overstate this. It is not only just, it was part of the challenge that we had during the course of the project, but once we were able to come up with good communication activities, we were able to be very successful and get a lot of folks on board with this project. Rallying around large process with intense focus will produce improved metrics and practices. You know, it was a very huge effort, and again, it was complicated by the number of different individuals and organizations that were involved. But I have to say, it was incredibly valuable to learn from, and then to have a number of individuals very much focused on this specific activity for a long period of time. It wasn't just a 2-week or 4-month type of project. It was over 30 months that this was a very focused part of what we were doing every single day. Using tools that are developed in collaboration with clinicians and end users are incredibly beneficial, and I've spoken about some of those as well. And sharing of ideas and learning models, effective and less effective strategies, has moved us forward beyond where we might have been otherwise. So, you know, we could have continued to do this type of work and put into place initiatives that were specific to our hospital. However, as part of the collaborative and learning with 9 other hospitals, adapting what they had done, sharing what we had been able to do, really helped the collaborative and all 10 hospitals much more greatly than what we would have been able to do on our own. So, in summary, the project was able to move us, and we were able to achieve our goals, which was to increase the overall care, specifically around cardiovascular disease. We were able to implement specific strategies that then were able to be applied to other patient types and diseases. We were able to collaboratively make a difference in the lives of our patients, and then also being able to combine the activities in the inpatient and the outpatient setting to really create that greater continuum of care and that this as patients transition from not just the inpatient setting, but to the outpatient setting as well. And with that, I'll stop and entertain some questions.
Thank you, Chris, for this brilliant presentation. And we already have a couple of questions in. The first one would be from Marion Street. She says that she noticed many strategists are focused on smoking, diet, and obesity. And she's asking, did you also address alcohol consumption? And if so, what strategies did you use there?
That's a great question, and with regard to alcohol, that was not something which we ended up focusing on. What we saw when we did the market assessment and understanding the different challenges that our community was having, alcohol was not one of the highest rated ones for this specific community, and so what we did is we didn't necessarily focus on that, but we focused on the ones that rose to the top, which really were nutrition, access to the care, and then also specifically around smoking. At the time, those were the ones that rose to the occasion, but alcohol was not one that really did, and so we didn't have a focus on that. That's a good question, though.
Thank you so much for this. The next question would be, what was the biggest challenge you encountered during this effort?
So I think I had referenced this already when I was talking about communication. When you have such a large project such as this, and you have a lot of individuals that are involved in creating and then driving this process, communication is the biggest challenge that you have because you have to be consistent, you have to be saying the same thing out with other folks throughout the organization, and then you also have to make sure that folks from the very top of the organization to the folks that are delivering care go throughout the organization, that you're able to support and make sure that barriers are removed, you have the support you need, that if you're going to be serious about any type of change around a big disease and a big patient group, you need to make sure that all hands are on deck and you're able to focus those activities very consistently and then coordinate them well. Communication, though, is kind of the glue that keeps all that together. And I have to say, early on in this project, it was very hard to get the communication consistent and to also make sure that folks were well aligned towards the end goal. There are a couple things we did internally to change that, such as bringing different people into the group that we had formed, providing a little bit more communication on a regular basis throughout the organization so folks have better visibility to what was going on, and a few other things that I would say by the 6th month, 7th month, we were able to address that particular concern.
Thank you, Chris. And another question, if you were to do something differently, what would that be?
Well, now with the question around alcohol, I think that we might want to focus on that because that was something lower on the list, but it was one of those characteristics that was out there that we need to address. But I think that what we would have done is not so much specifically around the cardiovascular piece of things, but what I would have liked to have done is actually start replicating this around other diseases a little earlier on. So while this was a major focus for 30 to 32 months, I would have liked to maybe towards the last 6 months of this project start replicating this with another disease. Because you would still have the focus on the group, but then you can start transitioning a little bit earlier to another disease and having some of that focus on other aspects of care and other aspects of the hospital that you might be able to get some of the team focus.
Chris, we might have lost you. Can you hear me? Chris? We're having some technical difficulties at the moment. We'll just see whether we can get Chris back online with us because it seems like his audio has gone.
Tandem or in parallel with
Chris?
the work we're doing with cardiovascular
Chris?
might have been helpful. Yes.
Sorry
Yes.
for interrupting you. We couldn't hear you for the last maybe 20, 30 seconds, so I'm not sure what exactly was the last of your words. So if you don't mind just going over answering that question again. We couldn't hear you at all, and neither could the audience.
Okay. Can you hear me now?
Yes, we can hear you perfectly now.
Okay. So what I was saying is if I were to do something different is I would have tried to incorporate or transfer some of the learnings with another disease earlier on. What I was saying is that towards the end of this project, we didn't look to replicate the success of this or the activities to another disease until this project was finished. And I think we lost some of the momentum because we waited until the very end. What I would have done is maybe 6 months or at the last 6 months of this project, we would start looking at another disease to start incorporating this in there. That's what I would have done.
Perfect. Thanks very much for going that over again. The next question would be from Francois, and he's asking, will the compliance to discharge contract be assessed over time and its impact over key metrics such as readmission rate?
Yes, those metrics are continuing and they're ongoing. And as part of what we do in the United States, we are constantly measuring the readmissions, and that in the United States, actually, we are penalized from payment for Medicare patients, patients that are age 65 and older, if we are not in compliance with kind of the best examples with regard to what those readmission rates should be. So definitely from the readmission metric, we are continuing to be measure that ongoing, and that's a key piece of what we do. And the order sets as well and the other activities, yes, they are also part of the ongoing process. The metrics did not stop being measured with the conclusion of this project. They continue because they're really baked, if you will, into a lot of what our metrics and our reporting is in the United States.
Thank you, Chris. The next question would be, how did you align disparate stakeholders towards a common goal?
And that goes to the communication discussion that I had a little bit earlier on. But with regard to aligning the different types of stakeholders, I think that it was important to, one, make sure that at the very beginning of the project, we selected the right folks that were able to champion the process. So we had a cardiovascular, we had an interventional cardiologist that was very well respected and was able to speak very well about the project, about where we're going, and help to get other folks on board. We had other leaders within the organization that were able to do the same thing. So that alignment came through recognizing that the right people were on the team, that these were activities that we're going to be focusing on, that the overall organization is focusing on, and they are very important to the organization. And that was communicated, and the right team was able to then move forward with that alignment because everybody had that sharing with regard to the responsibility for the outcomes, because everybody recognized in the end that for the patient, this is what's going to be able to provide the best care for the patient. And that was part of the alignment that we were able to put in place. So it's communication, it's alignment of goals, and it's also focusing on that end goal, which is the patient.
Thank you, Chris. It seems that would be all questions that we have so far. So I just want to remind everybody to type the questions into the question box if they have any extra ones. And also, just to let everybody know that the recording of this webinar will be available on the ISQua website within 24 hours. So please pass the information to anybody who you think might benefit from this webinar. It doesn't look like we have any more questions, so I'm just going to wrap up, and let me express huge thanks to Chris for this brilliant presentation and for his time today, and also to thank you all for attending this session. Just apologies for the delay with starting the session, and thanks very much for bearing with us, and thank you again, Chris, for brilliant presentation. Have a good day, and goodbye to all.
Thank you.